from the Asia. And good morning to all those who have been there from the US as well as from the Europe side. We welcome you all to the fourth class of P2P Febinar series. And, today, one of our fellow Dr. Awais Abbas, we're going to present on sepsis phenotypes. Before I will move on to him, it's a privilege and an honor to have a senior panelist in this session. I wanted to introduce Dr. Carcelo, who is a professor of pediatrics and critical care medicine at University of Pittsburgh. He has studied pediatric sepsis for more than 30 years and has published a lot on and have a lot of manuscripts on it. He was the task force chair for all three versions of ACCM, that is American Critical Care Medicine, hemodynamic guideline for management of pediatric and newborn septic shock. His present work is mainly focused on identifying multi-organ dysfunction phenotypes in pediatric sepsis. We have an honor to have Professor Arun Bansal. He is currently working in PGI IMER Chandigarh in Pediatric Critical Care and Advanced Pediatric Center. He is General Secretary in Pediatric Intensive Care Chapter. He is editorial board in Indian Academy of Pediatrics, as well as he is a member, executive board member for PediStars. We also have an honor to have one of our quite known, well-named in pediatric critical care medicine, Professor Harun Rashid. He is a professor and chair of pediatric ICU in King Edward Medical College, and he has a significant contribution to pediatric critical care medicine in Pakistan. So with this, I will going to give the dice to Awais Abbas, who are going to discuss and give presentation on sepsis phenotypes. Abbas, you can go ahead and you can start.
Okay, thank you so much. Good evening to all the persons who are attending this presentation. My name is
just Dr. one thing. So if there are any questions, you can write down in the chat box. We can have question and answer sessions after the presentation. Thank you.
So can you see my shared screen, Dr. Naveed, in attendance?
Yes, we can share. We can see.
Okay, fine.
Can go ahead.
So good evening to all the attendees. First of all, I would like to say thank you to all the organizers and the faculty members that have actually given me this opportunity to share this platform and share a bit of knowledge that I have and that I have studied. So today I'll be discussing different phenotypes of sepsis, and this will be a very brief overview of phenotypes. We're not going to plunge deep into the seas of the pathophysiology or different manifestations. It will be a brief overview for like all people to understand that how sepsis can manifest in different forms and how to investigate that and how to manage to achieve a good outcome in our patients. So I have no conflicts of interest to declare here. The highlights of my presentation are that we will going to be starting from a multi-organ dysfunction syndrome or multi-organ failure after a brief overview of sepsis. And then we will straight away jump to the immune paralysis pathophysiology. So immune paralysis pathophysiology that actually acts behind all the sepsis manifestation stuff. After that, we will be discussing the individual sepsis phenotypes that are IPMOF, TAMOF, and SMOF. And that will lead us to the MAS, the common pathway, the macrophage activation pathway. At the end of the presentation, we'll just give a touch up to the clinical and therapeutic implications. And we will discuss few of the future prospects that we think can be done. So I'll start with that why we discuss sepsis so commonly. So the sepsis, because it is still the leading cause of death in most of the intensive care units of developing countries, especially with a high mortality rate around 10 to 20%. That is from the Developed countries, although there has been a significant decrease in recent decades from 1994 to 2014, and now it is in single digits. But the PICU mortalities of sepsis in developing countries is still touching 50% odds. And why we are discussing phenotypes here in this presentation? So what are the benefits that we are going to achieve from this? So my thought process is that the general management principles of sepsis have essentially been the same. It is being followed by all the people from starting from the residents who work in the emergency departments. So we know 3-4 basic stuff. We have to initially recognize what is the actual condition. We have to start with the fluid resuscitation, and then comes the step of vasopressor therapy. And then another thing is that you have to instill the antibiotics. So these are the initial steps that everyone knows and everyone follows in almost all the emergency departments. But no particular clinical or any investigation pattern have been actually thought of, or any correlation made to the outcomes in patients. I will explain it. Like, for example, if we have a patient with sepsis, we have two patients with sepsis. One is with thrombocytopenia and one is with normal platelet counts. So normally we on general principles manage both of these cases in the same way. But after inshallah we'll be discussing these phenotypes, we'll be able to get a point that there are many differences in the pathophysiology of both of these lab manifestations, and that might end up both of cases might end up having completely different management strategies for an optimal outcome. So we remember that no two identical cases respond in an identical way, and no particular clinical or any lab evidence is by chance. So I was speaking of the correlation, so that the correlation that we usually do not make. So there is a correlation between sepsis and a particular set of clinical and lab evidence, and that correlation I call it a phenotype. So correlation between a particular clinical manifestation and a particular lab evidence is phenotype. What phenotype has actually inside? So phenotype has every phenotype has a different pathophysiology. Every phenotype has different clinical manifestations. There are a different particular set of investigations to diagnose that particular phenotype that actually guides us to different management strategies for each phenotypes. And what will we be achieving after prompt identification of these phenotypes? So we will be then able to use targeted use of resources. We'll be able to do that. Specifically speaking of resource limited countries, we'll be able to timely and appropriately manage our patient, and after that we'll be expecting a better outcome for our patients. So I'll just quickly go through a study trial that was conducted by Dr. Carcelo himself. So just a brief overview, he had 100 patients with sepsis, in which 25 were cases of single organ failure, as mentioned here. And he had 75 patients with multi-organ failure. So this is the mortality chart that shows that there is no mortality in the single organ failure group. All the mortalities have been in the multiple organ failure groups. And the important point to note here is that in the multi-organ failure group, so you can divide into two categories: a subset of multi-organ failure without these phenotypes, and a subset of patients of multi-organ failure with these phenotypes. So the mortality that has been observed is in the second arm. So all the patients who died were having multi-organ failure with any of these three phenotypes. And no patient actually died who wasn't having any of these phenotypes. So that is why discussing these phenotypes is very important. So I'll explain this slide in detail later on in my slides. I'll quickly go through the definition of sepsis, just for sort of a brief overview purpose. So sepsis is a life-threatening organ dysfunction that is caused by a dysregulated host response to infection, and we'll actually look into what I actually mean by dysregulated immune response. So the definition of septic shock is like circulatory, cellular, and metabolic abnormalities that requires vasopressor to maintain the mean arterial pressures with a high serum lactate of greater than 2 in the absence of hypovolemia. Organ dysfunction, we define it as the sequential organ failure assessment score, the SOFA scores of 2 points or more. The term multi-organ failure, or you can call it as MODS, so it was first defined in 1991 by the Society of Critical Care Medicine. We define it as the presence of altered organ function in an acutely ill patient, such that the homeostasis cannot be maintained without any intervention. So this is how the SCCM defined multi-organ failure. Just one slide about the epidemiology of multi-organ failure. So the incidence of multi-organ failure, it varies. It has a large window. It varies from 17% to 73%. Again, with a very broad mortality range window that is from 19% to 57%. And incidence of multi-organ failure is twofold greater in patients who have any comorbid conditions. And this also increases the risk by 60% when we control it for the number of dysfunctional organs. So it means that the more the number of dysfunctional organs we have in a patient, the increase the percentage of mortality we get. Just two slides. I will briefly and quickly go through individual organ dysfunction definitions. Regarding cardiovascular dysfunction, we define it as hypotension less than 5th percentile for age, or systolic BP less than 2 standard deviations below normal for age. And when we need vasoactive drug to maintain the blood pressure, or like unexplained metabolic acidosis, the increased arterial lactate, the 2 times upper limit of normal, oliguria comes in here as well, less than 0.5 ml per kilo per hour. If you get prolonged capillary refill of greater than 5 seconds, and core to peripheral temperature gap is greater than 3 centigrade. Respiratory organ dysfunction is defined as the PF ratio less than 300 in absence of any cyanotic heart disease or pre-existing lung disease, or PaCO2 of greater than 65 or 20 over the actual baseline of PaCO2. If we prove that the FiO2 need is of greater than 50% to maintain the arterial oxygen saturation of greater than 92%, or if the patient needs any non-elective invasive or non-invasive ventilation. Coming to the neurologic definition of organ dysfunction, so if the Glasgow Coma scale shows a score of less than 11, or if there is any acute change in the mental status, or a drop of 3 or greater than 3 in the GCS from the baseline. Hematologic dysfunction is defined as like having one or more of the following: if the platelet counts drop below 80,000, or a decline of 50% in the platelet count from the highest value that we recorded over the past 3 days, and if the INR is greater than 2. The hepatic dysfunction, we define it as the total bilirubin of 4 or greater than 4 ml per deciliter, and ALT if ALT is greater than 2 times the upper limit of normal for that age. And renal dysfunction, the last one, so if serum creatinine is greater than, equal, or greater than 2 times rise as compared to the upper limit that is normal for that particular patient's age, or greater than 2-fold increase from the baseline creatinine. So these were the 6 basic organ dysfunction definitions that obviously we carry on when we discuss multi-organ dysfunction. I'll now focus myself on the immune paralysis that actually is the crust of the multi-organ dysfunction. That is the mechanism that is happening behind the multi-organ dysfunction. So it is sepsis-induced immune dysfunction that is actually characterized by lymphoid cell depletion and prolonged monocyte deactivation. And it is the basis of sepsis-induced multi-organ failure in children. How it does that, we'll be going to discuss that in coming slides. So this is a chart that I'll discuss. So basically, we have here a y-axis and an x-axis. So on y-axis, we have the immune response of a patient. On top of that, it is hyperinflammatory response, and on the lower end of that, we have immunosuppressed response. And on the x-axis, we have the timeline through which the patient goes when he is critically ill. So basically we get so we can divide patients into two subsets. A subset of patient that actually goes into the hyperinflammatory response category, going above the central line, and a subset of patients who land up in the lower aspect of this figure, the immunosuppressed type. And there are actually three fates. I would like to point it out. So actually there are three fates, or three stages in which the patient can land in. So if the patient who is having any hyperinflammatory response, the hyperinflammatory response actually shoot up very quickly without achieving any plateau, and the patient can succumb to the critical illness and overwhelming inflammation, and patient can die very early. The second arm is, but this early death or overwhelming, because of overwhelming inflammation, usually is not seen in the immunosuppressed category, as it is not mentioned here in the lower half of the figure. So, if the patient somehow managed to go through this stormy phase and turbulent phase of the inflammation, that hyperinflammatory response patient might take another loop and might go down to the immunosuppressive stage with persistent immunosuppression that will result in development of secondary infections, and that can cause late deaths potentially. And if the patient even goes beyond that stage that is showed by this purple line, so patient might be having prolonged immunosuppression, and that can cause significant comorbidities as well as mortalities. Immune paralysis dysfunction. So what sepsis does? So sepsis actually causes progressive and profound depletion of the immune cells. So everyone knows these two arms that we have in our body, the innate immunity arm and the adaptive immunity arm. The innate immunity arm comprises of neutrophils, monocyte macrophages, the dendritic cells, and the natural killer cells. And the adaptive arm comprises of B cells and CD4 T cells and T regulator cells. So just a picture to show these two arms that we have and the different cells. In the coming slides, I'll be discussing what happens with the individual cell lineage in the immune paralysis pathophysiology. The main concept behind the immune paralysis, the main damage, the main thing that happens to the cell is the apoptosis. So it is the major mechanism of immune death in septic patients. So both death receptor and mitochondrial pathways, they act as multiple triggers to trigger the apoptosis of a broad range of subsets of all the immune cells that we have in our innate immunity arm as well as in our adaptive immunity arm. What I have got from the literature search, there are few promoters of apoptosis as well. So these are few promoters that actually promote the apoptosis of the immune cells that leads to the development of multi-organ failure. So among the promoters, we have monocytes that act through the fast-mediated apoptosis of T lymphocyte. We have caspase-1 that causes apoptosis of splenic B lymphocytes. We have programmed cell death ligand 1 that causes T cell exhaustion. We have endoplasmic reticulum stress that mediates lymphocyte apoptosis, and we have got BCL2 at the end. That is an anti-apoptotic protein, as is found to be actually reduced in sepsis. So that causes exaggerated apoptosis of our immune cells. So again, a figure in which the patient when develops sepsis, so it affects generally both of the arms of our immunity, the innate immunity arm and the adaptive immunity arm. And both of these combinedly result in protecting significant immunosuppression, leaving the patient rendered to open to being hit by any opportunistic or even any low-grade infection that can potentially cause severe morbidity and mortality. I'll discuss individual cell lineage, that how these cell lineage get affected in the immune paralysis pathway. So for neutrophils, what I have got out from the literature search, so there are basically two mechanisms through which the neutrophils get affected in the immune paralysis. We all know that it is neutrophils are the most abundant leukocytes in the systemic circulation. So what happens in the early stages of sepsis, the level of neutrophils increase rapidly. That is the reason we get a high neutrophil count in the first 24 hours. And and also it causes, we also encounter a persistent neutrophil dysfunction, and this dysfunction actually triggers the release of immature neutrophils from the bone marrow. So when immature neutrophils actually flood in from the bone marrow into the systemic circulation, what they do, so what we then get, so we have then deficits in the oxidative bursts, we have deficits in the cell migration, and in deficits in the complement activation, and obviously deficits in the bacterial clearance as well. Another mechanism that has been discussed in the literature is that when neutrophils phagocytose the bacteria, they form neutrophil extracellular traps. So we call it nets. After formation of nets, the neutrophil undergoes respiratory bursts and they die, and those nets are actually released into the circulation. So when those nets are released into circulation, they're actually broken down into free DNA, they are broken down into histones, and they become a source of triggers for infections. So we call those triggers as damage associated molecular patterns, and the short form is DAMs. So I'll be discussing this DAMs in the coming slides. So the stronger the net formation, the more severe the sepsis is generally, and it is the stronger net response is associated with multi-organ failure and ultimately poor outcomes in the patients. Now, what happens to the monocyte and macrophage lineage in the immune paralysis phenomena? So with the progression of sepsis, there is excessive apoptosis and there is excessive dysfunction of the monocyte macrophage line as well. So what happens that there are two things that happen. In the first place, there is decreased release of the pro-inflammatory cytokines such as TNF alpha, interleukin 6, and interleukin 12. And after that, that is followed by release of anti-inflammatory mediators such as interleukin 1 receptors antagonists and interleukin 10. So there's a decreased release of pro-inflammatory cytokines with increased anti-inflammatory mediators that results in suppression of the mononuclear cell HLA-DR expression on the surface of monocytes. And all this pathophysiological alteration results in the monocytes and macrophaging not functioning normally, and these are ultimately associated with nosocomial infections and increased mortality. What happens with lymphocytes? So T and B lymphocytes subsets are significantly changed by the sepsis. So we actually encounter a decreased count of these cells because of exaggerated apoptosis. So we get CD3, CD4, and CD8 lymphocyte counts, which are having significant drop in septic patients. The ratio of the Th1 to Th2 helper cells, it also is significantly lowered in sepsis. And another thing is that CD3, CD56 cells, these two particular cells, they show a particular largest decrease that have been observed in the data. And their decrease is very strongly associated with the sepsis severity and mortality. A bit of natural killers discussion here. So what actually happens with them? So they increase in early sepsis, and their higher levels actually predict mortality. And once the literature that I got to review showed that the ratio of natural killer cells to CD4 lymphocytes, this ratio has been actually used to predict the mortality of patients with sepsis. So higher the ratio, the higher the mortality that we are going to be expecting. So I'll just touch base the concept of pathogen-associated molecular patterns, or PAMs. We call it PAMs. So what are PAMs? So PAMs are actually activated by a diverse group of molecular motifs found on pathogens that we actually label as PAMs. So like if I would to simplify this, so these are molecular triggers that are released by the pathogens that actually trigger the immune paralysis cascade. So these are the molecular triggers that are released by the pathogens. So the most well-studied PAMP is lipopolysaccharide. Everyone knows that. So LPS, a component of the outer membrane of gram-negative bacteria. So LPS, but specifically its lipid A component, it is the key initiator of endothelial barrier dysfunction during sepsis. I'll just go through the concept of DAMs as well. So I'll go through the concept of dams as well. So what are dams? So dams are the mediators that are released from the cell following cell death. So these are the mediators that are not released from pathogens. These are mediators which are released from the inherent body cells, our cells that are lysed, that get damaged. So in sepsis, a large number of immune cell death releases a large quantity of dams. And what dams actually do, they trigger the host immune response that leads to the activation of coagulation, and that ultimately leads to the development of multi-organ failure. And dams has got a central role in development of sepsis and its progression towards multi-organ failure. These are few examples, 5 of them only, the dams that actually that has been shown in the literature: the histones, the DNA particles, the heat shock proteins, the ATPs, and the mitochondrial DNA. These all things actually act as dams, and these are released from the innate body cells, which are apoptosed, and these actually are then triggers to induce the multi-organ failure. I will just discuss mitochondrial DNA, that is a dam. So we all know, at least the literature that I have searched, that it shows that the shutdown of mitochondria, it plays a vital role in the pathophysiology of multi-organ failure. The concentrations of plasma mitochondrial DNA, it has been seen over the trials that the concentrations of the plasma mitochondrial DNA, it is significantly greater in patients with multi-organ failure as compared to the patients without multi-organ failure. And mitochondrial DNA, so it does act as a dam that on its release into the extracellular space triggers the immune system, and that leads the patient towards multi-organ failure. So this is the chart that actually summarizes all this concept of immune dysfunction. So when the patient gets infected, then what happens? I'm not getting a picture. So okay, so fine. So when a patient is actually affected, patient gets a local bacterial infection, and after that, it triggers an abnormal immune response and to the PAMs, from PAMs that originate from that bacteria. So they will affect lymphocytes, they will affect neutrophils and other immune cells. So neutrophils will go on to form the nets. The lymphoid cells will be going to lyse, and excessive immune cell death. Both of these things will collectively produce more and more dams. So what dams then do, they actually, these are the dams, they actually cause microangiopathy, they cause thrombosis, they lead the patient towards DIC, they call cell membrane pore formation, they cause endothelial damage, microcirculatory impairment. So when these all things actually combine together, so they lead patient to multi-organ failure and sepsis. One important thing to see here, there are multiple things that we actually, multiple interventions that we can actually do to actually prevent the patient from sliding down into the multi-organ dysfunction. So there are anti-net therapies like anti-interleukin 8. We have anti-DEN therapies like antibodies and non-anticoagulants like heparin, DNase. We have anticoagulation therapy, antithrombin, low molecular weight heparin. We have got immune modulators in the form of interleukin 7, interleukin 15. We have got anti-apoptosis therapies, anti-caspases therapies. So these are the intervention or the modalities that we can actually indulge in for a patient who is at risk of going into the microangiopathy and subsequently multi-organ failure. So after the, like we have discussed the general concept of the immune paralysis with individual cells that get affected, how they get affected in the immune paralysis and they lead the patient towards multi-organ dysfunction. We'll now discuss the phenotypes. We'll go through the definition. We'll a bit like touch base the pathophysiology. We'll see how to investigate them, and we'll briefly, very briefly, go through the management aspect of the phenotypes as well. So 3 inflammation phenotypes have been reported to respond to pathobiologically targeted therapies. So we have got three described inflammation phenotypes. The first one is immunoparalysis associated multi-organ failure. Second is thrombocytopenia associated multi-organ failure. We call it TAMOF. And the third is sequential multi-organ failure that encompasses a new hepatobiliary dysfunction. So all of these three phenotypes have got multi-organ failure with them. We're going to be individually discussing each of these. I'll start with the IPMOF, the immune paralysis associated multi-organ failure. So what is IPMOF? So it is a clinical syndrome in which depressed monocyte biomarker levels are associated with adverse outcomes and increased nosocomial infection rate. So this is the theoretical definition of this syndrome, in which we get a depressed monocyte biomarker level. So what are that? So the below one is the biochemical definition of IPMOF. If we define it biochemically we define IPMOF as whole blood LPS stimulated TNF alpha response that is less than 200 picogram per milliliter after 3 days of multi-organ dysfunction or at death. So the whole story of the IPMOF actually rotates around the TNF alpha response from monocytes. Coming to the pathophysiology, so this slide shows what should be the normal physiology. So what happens at LPS stimulation of the toll-like receptors on monocytes, they normally should induce a rapid TNF alpha transcription, translation, and release. And the capacity of the whole blood to produce TNF alpha after stimulation with LPS. So this capacity of TNF alpha production has been used as a biomarker of monocyte function in the critical illness. So this is something that is normal physiology that happens in a normal person. So what actually pathologically happens here in the IPMOF? So actually we get reduced expression of monocyte cell surface molecules that are HLA-DR. These are monocyte cell surface molecules that are important for the antigen presentation. So when there is reduced expression of these molecules, it is associated with adverse outcomes, including the development of nosocomial infections and death and sepsis. So and the story behind this is that because there is reduced capacity to produce TNF alpha after stimulation with LPS, and that is associated with adverse outcomes. A subset of labs that we can carry on with for diagnosis of IPMOF is the total leukocyte count and the differential leukocyte count. TNF alpha response that by definition should fulfill, it should be less than 200 picogram per milliliter. The differential lymphocyte count with differential CD4 and CD8 T lymphocyte subsets. And besides that, the supportive lab evidence can be of interleukin 6 levels, the procalcitonin levels, and the body fluid cultures. Very brief management review of IPMOF. So what we target in the management of IPMOF, we since it is an immune paralytic state, so we target to provide immune modulation to counter this immune paralysis. So 3 therapies that have been worked upon that I have searched in the literature. One is the interferon gamma, that is a potent immune stimulatory agent. Other is GM-CSF, the granulocyte colony stimulating factor. And the third one is cytokines, that are interleukin 7 and interleukin 15. So one strategy that offers promise is the use of anti-apoptotic immune stimulatory cytokines. As I discussed, interleukin 7 and interleukin 15 we have here. So what does they do? They actually prevent cell death. They diminish the immunosuppressive effect that the uptake of the apoptotic cells has actually on the phagocytic cells. So this is the first modality. The second modality that has been worked upon, that has been studied extensively, is the granulocyte macrophage colony stimulating factor, GM-CSF we call it. So it is a growth factor basically with potent immunostimulatory effects. So what it does actually, so it enhances the antimicrobial host defense, and then what we actually get, so they improve the host cell survival. the proliferation, differentiation, the phagocytosis, and bacterial killing of the neutrophil and the monocyte macrophage entities. And by doing these mechanisms, actually immunomodulate and provide the immunostimulatory effect to counter the immunoparalytic effect of IPMOF. I'll quickly go over to the second phenotype, that is TEMOF, the thrombocytopenia associated multi-organ failure. So how do we describe as? So this is a clinical syndrome that is characterized by new onset thrombocytopenia that coincides with evolving multi-organ failure. So it starts with new onset thrombocytopenia, and how it happens, so we're going to be looking forward to that. So clinically, we diagnose it by a triad of thrombocytopenia and at least two failing organs like acute kidney injury or acute lung injury, and the pathophysiology behind those failing organs is the microangiopathy. The hallmark lab biomarker for TAMOF, the hallmark lab biomarker for TAMOF is the low activity of ADAMTS13. We also call it as von Willebrand factor cleaving protease. So what it does, we'll be looking at it. Before I describe ADAMTS and von Willebrand factor cleaving protease, so basically, TAMOF encompasses three very common clinical scenarios that I'm sure everybody would be experienced in dealing with. So these three clinical entities that are commonly described are thrombotic thrombocytopenic purpura, TTP, which is actually dominated by neurologic abnormalities. The other one is hemolytic uremic syndrome that is characterized by prominent acute renal failure. And the third one is secondary thrombotic microangiopathy, TMA. So these actually three common clinical entities. On background of these three entities, the pathophysiology is same as of TAMOF. So a small picture that actually shows what is going here. So by like any toxin or any bacterial, I should say now PAM can induce endothelial injury that results in a platelet aggregation here, and also cause hemolysis that results in the production of schistocytes. And besides that, hemolysis has occurred and schistocytes are being produced and platelet clumps are being formed because of the endothelial injury. ADAMTS levels also get decreased. That results in non-cleavage of the multimers, the von Willebrand multimers. These are multimers, these are large size, these are normally cleaved, but because of the deficiency of ADAMTS13, they are not cleaved. So actually they further recruit the microangiopathy phenomena, further recruit the platelet and microthrombus formation that actually leads us to development of multi-organ failure. So this is the pentad of TTP. Just for a brief revision, we get fever here, we get CNS abnormalities, renal pathology, thrombocytopenia, and microangiopathic hemolytic anemia. So this is the pentad of TTP. Coming to the pathophysiology of TAMOF. So ADAMTS13, what it does? It actually regulates microvascular thrombosis by cleaving the large thrombogenic von Willebrand factor multimers into smaller and less hemostatically active forms. So it actually cleaves large multimers into smaller forms. What happens if the large forms are not cleaved and the large forms persist in the circulation? So what happens that they recruit platelets. So platelets actually adhere to the uncleaved large multimer forms of von Willebrand factors, and as a result of that, they form a microvascular aggregates on the endothelial cells that results in microvascular occlusions in all of the organs of the body that are rich in platelets and von Willebrand factors. And when this happens, when microvascular occlusion happens in different organs of the body, so this is the stage when the patient actually lands into the multi-organ failure. A brief overview of the investigations of TAMOF. So important investigations that have been highlighted are ADAMTS13 levels, of course, that is the main game changer behind the pathophysiology, and the platelet count that is obviously including the definition of that. We get a low platelet count, we get a low level of ADAMTS13. For supporting evidence, we can get peripheral smear done, hemoglobin can be low, we get LDH that is on the higher side, and supportive lab evidence other than that are plasminogen activator inhibitor level, D dimers, and body fluid cultures as well. The management of time off. So the target strategies for time off management are three. The first is number one, that we have to replenish ADAMTS13, that is actually decrease in the time of pathophysiology. Number second is we have to remove ADAMTS13 inhibitors that are one of the cause of decreased level of ADAMTS13. And then number third is we have to remove large von Willebrand factor multimers that are in the circulation because of the decreased level of ADAMTS13. So what I found in the literature search regarding the management of TEMOF, two modalities. The first one is the plasma exchange therapy. So plasma exchange is actually believed to be efficacious because it replenishes ADAMTS13, it removes the ADAMTS13 inhibitors, and it removes the von Willebrand factor multimers as well. I went through a data as well that compared the plasma infusion therapy with plasma exchange therapy as well. What plasma infusion can do, it can only replace the deficient ADAMTS13 levels, but it cannot, since we are not taking out any plasma, so it will not be able to remove the inhibitors. So this plasma infusion therapy proved to be less beneficial than plasma exchange therapy for time off management. One other management aspect is the eculizumab. So many trials have been done on this as well. It is a long-acting monoclonal antibody that is targeted against the complement C5. It inhibits the cleavage of C5 into C5A and C5B, and subsequently it inhibits the deployment of the terminal complement system. So by that it stops that microangiopathic pathway. The trials have shown that by giving eculizumab, they actually got good encouraging results with an increase in the platelet count, and almost 80% of the patients were having those thrombotic microangiopathy, were having this angiopathy free status. Almost 80%. This is a large number. The eculizumab also, the trial also resulted in time dependent increase in the estimated GFR of the patient as well. I'll go through to the third phenotype, that is sequential multi-organ failure, ASMOF. So what is ASMOF? ASMOF is the phenotypic syndrome that is characterized by respiratory failure followed by hepatic and renal failure. What happens that it leaves, what ASMOF does, it leaves the natural killer and cytotoxic T lymphocytes, these two subsets, with an inability to induce death of viruses or activated immune cells. What happens in the viral infections? So viral infections cause lymphoproliferation with soluble Fas ligand release, hemophagocytosis, and soluble Fas ligand mediated liver injury. I'm going to discuss it in the next slides. So coming to the normal mechanism of the Fas ligand. So this is a mechanism that works here in the pathophysiology of asthma. So the Fas ligand system is recognized as a major pathway for the induction of apoptosis in the activated immune cells, or the disease cells, activated immune cells, or the infected cells, you can say. The Fas antigen belongs to the TNF family and is often expressed in thymus, ovaries, heart, kidneys, and liver, and different tissues of the body. The Fas ligand is a protein that gets bound to the Fas antigen on surface of any cell. Okay? And the Fas ligand, when it comes in contact with Fas, it induces apoptosis of that target cell. Now, pathologically, what happens? So there are two mechanisms by which this pathology actually harms the patient. So what happens that there is a release of a soluble form of Fas that we call a soluble Fas that is capable of blocking the interaction of Fas and Fas ligand, and thereby it actually prevents the apoptosis of the infected cells or the activated cells. And when the infected cells or activated cells are not apoptosed or they are not killed, so it results in a hyperinflammatory response. The other mechanism through which the Fas ligand works is that it is capable of inducing a direct cytotoxic injury to the hepatocyte by binding to the hepatocyte FAS as well. The investigation for ASMOF are obviously soluble Fas and Fas ligand levels, interleukin 10, interleukin 6, the viral PCRs like Epstein-Barr virus or the CMV or the other viral causes that can potentially cause this pathophysiology. We can get body fluid cultures and TNF-alpha levels as a supportive evidence as well. The management of ASMOF, so the targets that we have to set for management of ASMOF is we have to target killing of the virus through antiviral treatment. Second is we have to target the killing of the activated immune cells or the infected cells by reducing the immune response or the immune suppression. The modalities that have been seen, that have been used, and that have been discussed in the data are IVIG and methylprednisolone. One important management aspect is the deployment of rituximab. So everybody knows that it is an anti-CD20 monoclonal antibody that elicits the lysis of CD20 positive normal and malignant B cells as well. So what then happens that like antibody actually rapidly induces the depletion of mature B lymphocytes. So it reduces the compartment or the bulk of the EBV infected B cells. And that is the reason it is one of the top line therapy agents for asthma right now. The final phenotype that is a phenotype in a sense, but that actually shares a chunk of all of these phenotypes as well. So this is the macrophage activation syndrome. So we call it the final pathway as well, because all of these three phenotypes have the potential to actually land up into the MAS pathophysiology. So what is MAS? This is a state of uncontrolled inflammation with the proliferation of macrophages. Just to simplify, so it is an uncontrolled inflammation because of uncontrolled proliferation of macrophages. So it is a severe and potentially life-threatening hyperinflammatory complication, which is response for the bulk of the mortality that have been observed and that I'll discuss in the later on slides and the data that we have reviewed. I'll just quickly rush through the clinical and lab criteria. So we have like 5 of 8 of the following symptoms that should be fulfilled in order to diagnose the patient of having MAS. So we have got fever, we have got splenomegaly, cytopenias with greater than 2 cell lines if they get affected, hypertriglyceridemia of greater to 265, or hyperfibrinogenemia, hemophagocytosis, lower absent natural killer cell activity, hyperferritinemia, and elevated soluble CD25. So after these 8 criteria, we need to fulfill at least 5 to diagnose a patient having MAS. So I'll quickly go through the pathogenesis. So what happens? So these are infected cells or activated immune cells. Okay, so these actually present the antigen to the lymphocytes that result in the Fas ligand binding and activation that releases interferon gamma, interleukin 2. The release of these two causes the recruitment of macrophages, and macrophages release interleukin 1 and TNF alpha, and that results in the inflammatory response. So what happens when Fas ligand pathway is interrupted because of soluble Fas? So what happens there? That ultimately it is not possible. It is not possible for the targets or the activated immune cells to actually activate lymphocytes. So lymphocytes here, these lymphocytes won't be actually able to kill these activated cells. So these activated cells or the infected cells will be able to trigger lots of the immune lymphocytes that will actually cause a gush of the macrophages, and that this gush of macrophages, it will result in a hyperinflammatory response that we call macrophage activation with lots of like surge of TNF alpha and interleukin 1. Coming to the pathophysiology very briefly on bone marrow. So it is dysfunction immune response. So bone marrow shows morphologically like it has the macrophages showing hemophagocytic activity, and these hemophagocytic activity cells, the macrophages, may also infiltrate into the many other organs like lymph nodes, liver, and spleen. The investigation panel that we have for mass is the ferritin, of course, the triglycerides, the fibrinogen, the WBC count, platelets, and hemoglobin, because these are included in the diagnostic criteria as well. And the supportive evidences of ALT, ASTs, and CRPs, ESR, albumin, LDH, and D-dimers. Management of mass is actually targeted towards the interleukin-1 receptor antagonism. So the agent that we have that has been extensively studied is anakinra. It has short half-life, over 3 to 4 hours. It has a wide therapeutic range, and high safety profile as well. The management aspect of the mass. So three main management strategies that have been extensively studied and deployed as well is the use of corticosteroids, the use of intravenous immunoglobulin, and the use of etoposide. Besides that, studies have been done on tocilizumab and infliximab as well. So this is a chart that actually combines all of these four phenotypes. Three main phenotypes, and other one is the macrophage activation syndrome, in which the clinical criteria of their definition has been defined as well, and as well as the confirmatory biomarker definition has been defined as well. So we have already gone through this, so I won't go into the detail of this chart. So first time in 2017, Dr. Carcello himself described these three hypothetical inflammation phenotypes and pediatric sepsis-induced multi-organ failure. Before that, these phenotypes weren't defined. The hypothesis was that children with one or more of these inflammation phenotypes have more inflammation that is indirectly indicated by higher CRP levels and ferritin levels, that is greater proclivity towards the development of feature of MAs, and has a greater risk of multi-organ failure related deaths. This was the hypothesis on which the study was actually conducted. So I'll now go through the two result pictures. The first picture is, let me get a clear view of this. So this is a single and multi-organ failure distribution in severe sepsis case. So this is the category of single organ failure patients. So there were total 100 patients. Out of that, 25 were having only single organ failure, and the rest 75 were having multi-organ failure. Okay. Now I will focus this circle. So in the multi-organ failure, this is the area that shows the number of patients who had multi-organ failure but who were not having any of these three phenotypes. So that number of patients was 38. So the subset of patients who had multi-organ failure and who had the IPMOF phenotype were 24. Patients with multi-organ failure with asthma were 6. The patients with and this is a subset of patients with multi-organ failure with TAMOF. And obviously, both of these three phenotypes have a triangular interaction. They have overlaps as well. So the 5 of the patients, let's see, 5 of the patients had both immunoparalysis, IPMOF, and TAMOF as well. Okay, and one patient was there in who had all of these three phenotypes simultaneously along with multi-organ failure. Okay, so now I will come to the lower part of the figure that shows the macrophage activation syndrome distribution in these 100 patients. So again, single organ failure, no patient had a case of mass, no patient was a case of mass. So all the cases were in multi-organ failure category. So the important point to note here is that the patients with multi-organ failure without any inflammation phenotypes, so nobody actually developed mass. So there is no case of mass in multi-organ failure patients who did not have any phenotype. All the cases of mass were in the patients who had multi-organ failure and any of these three phenotypes. So as the results show, patients of multi-organ failure with immune paralysis, 6 of those had mass. In TAMOF, 7 of those patients with TAMOF with multi-organ failure, 7 of those develop mass. And with patients of asthma with multi-organ failure, 2 of those develop mass. So, and the higher percentage that we saw was in TAMOF, around 47% of the patients actually developed macrophage activation syndrome. So this is pretty significant. The next figure here that we'll be discussing is the mortality. So again, there is no mortality in the single organ failure. Coming to the larger circle, so we see so again there is if we see this portion, so those patients of multi-organ failure without any phenotype, they did not have any mortality. So all the mortality that has been observed is in these between three phenotypes. So let's say like MOF, the total number of patients of MOF with phenotypes, there were eight mortalities, around 22%. Out of that, the contribution of IPMOF, the contribution of IPMOF. So it is a bit complicated. I will simplify. So the patients with MOF, with immune paralysis, and who develop mass. Okay, these three entities in a single patient. So the mortality was 21%. Okay, so the patient with multi-organ failure, with TAMOF, and with mass, macrophage activation, they had 40% mortality. And the patient with multi-organ failure, with ASMOF, with macrophage activation syndrome, they had 64%, they had 17% of the mortality. And the mortality of mass individually was 64%. So this is how significant these phenotypes are. So this picture particularly shows that both the subset of patients had multi-organ failure, but the patients without any these three phenotypes did not have any mortality, did not develop mass. And the patients having these three phenotypes actually had mortalities and they went into mass as well. I'll just be finishing with the presentation last few slides. So what are the clinical implications? What actually we think of after going through all the presentation? So studying different sepsis phenotypes, actually it shifts our focus to target specific phenotype as a suspicion in septic patients. And it like prompts us to do relevant investigations, and that will lead us to timely phenotype identification, and that will lead us to targeted and timely and appropriate management, and that will obviously result in decreased morbidity and mortality. For resource limited settings, this targeted approach can actually result in decreased length of stay and morbidity. It can result in decreased mortality, and we can actually prioritize the resources that we have in our limited setups. And definitely, it does have less socioeconomic impacts on the family as well. The initial impact of the phenotypic approach actually seems to be costly, but what we can assume that they have the potential to reduce the cost of care over a long period of time. A few future prospects that we can see or we can think of, that COVID induced sepsis. Where does the COVID induced sepsis stand? With MODS, does it stand as a separate phenotype? What is the interaction of the COVID-induced sepsis with these three phenotypes? The future prospects can include a larger multi-center trials that enable us for a better understanding of these three phenotypes, again because this is relatively a newish concept. And the multi-center trials will be enabling us to better differentiate between MAS and HLH, So these hyperinflammatory phenotypes are actually pretty intermingled, so pretty into each other. So a good differentiation is important. So the third point that I would like to make is the mitochondrial dysfunction and its management in MOD. Since the patient that we have encountered in our intensive care setup with mitochondrial dysfunction, they usually do not survive. So how can we carry on with that as well? So thank you so much for listening to this purely biochemistry based sort of, I would say, literature review. And so questions, the floor is open to questions. And I'll be listening for myself to learn as well.
Thank you, Wes. If you could stop sharing your slides.
Okay.
Okay, so thank you for a very elaborate presentation. I think you took us on a journey, starting off with why we think phenotypes are required, why an understanding is needed, especially in, resource-limited settings like ours, where we're just beginning to understand, and we actually end up, to be honest, labeling everything as mods, and send an array of tests, and then be it just one end of the spectrum or the other. But now I think we've got a, we started to get some about it. So I'll just give a brief overview of your presentation, and then we can open the floor for our panelists to let us know what their thoughts are on your presentation, and then we can take in any questions that we have. So you started off with presenting as to why we think learning and knowing about phenotypes is important. Then you talked about pathobiology and pathophysiology, discussing specifically how sepsis leads to immune paralysis and immune dysfunction and how that is important as a concept. Then you took us individually through each phenotype, explaining it in detail, starting right from the epidemiology and then taking us right through the physiology, pathology, and eventually how you actually end up managing those and what are the therapeutic targets. And of course, then you actually ended up with macrophage activation as a common pathway, and then discussing, some evidence of literature and whatever targeted therapies that we have. So with that, I'd like to invite Dr. Carcello to say a few words about Oasis' talk and what his thoughts are. And then I'll invite all panelists to say a few words before we can take in further questions.
And that was a wonderful talk, Dr. Abbas. Best I've heard, actually.
Thank you.
I don't have anything to add because everything you said I agree with, and I think it's brilliantly done. I could help when you're answering questions if Dr. Abbas, doesn't have an answer. I can help with that, I think, mostly. But I thought that was an amazing talk. Great job.
Thank you. Pleasure.
Dr. Arun, if you could go next and share your thoughts on the presentation.
Yeah. Thank you, Dr. Sidra and Dr. Abbas. I echo the same feeling. It was a wonderful presentation, very well structured, and you had a great flow. And you took us very nicely and explained it very lucidly, all the concepts behind. I know it's not easy. It's a difficult concept to understand oneself, but you made it, I think you had done a lot of homework and reviewed a lot of literature. So it reflected very well in your talk. So thank you. Great job. So we can take a few questions after this. Yeah.
Dr. Harun, if you could kindly share a few words. I believe
he has lost his connection.
There's some technical glitch at his end. Okay, so I think we can move on to questions. Dr. Naveed, you can start with taking the first few questions, and then I'll go next.
Okay, thank you very much. Avis, that was an excellent talk, and we'll move on to the question and answer session. Now the first question, it is by Dr. Arun. Now, what is the clinical role of GCSF in sepsis, and what is the difference between MAS, HLH, and hyperferritinemia?
Thank you so much, Dr. Arun. So, what I have, what the impression that I have got from the literature search, and up to best of my understanding, is that what after going through these actually phenotypes, so I now divert my mind towards actually putting in every patient and categorizing every patient to any individual phenotype. So how I see this as, okay, if I'll be better able to identify a phenotype, and if that patient, for example, lands into the time of category of the septic phenotype, then there comes the role of GNCSF, because there have been some trials. But for example, if a patient lands into the IPMOF category or the SMOF category, so as the previous trials have shown, so possibly I might not be thinking to use a GMCSF. So this is so just to cut short. So the bottom line is GMCSF would be helping us in that particular phenotype of sepsis that is the time off, and I would be happy to consider that. But other than that, so this is actually the understanding and the orientation that actually I have got from reviewing these phenotypes. Before that, I possibly wouldn't have been like saying this. So yes, so this is my understanding.
So if I can add,
Yeah,
so
for sure.
the way we use GM-CSF in practice is at half the dose that you use for oncology patients when you're trying to get bone marrow. And we do it for 7 days. Because if you do it as a high dose, then you'll get hyperinflammatory. But if you do the low dose subcutaneously or over 12 hours each day, you get the restoration of the immune system without the hyperinflammation. The way we define immune paralysis at the bedside is 2 consecutive lymphocyte counts less than 1,000. Or if we have the ex vivo TNF response, we'll use that. Now, presently, we're about to start a multi-center trial in October in 24 centers in the United States, where patients who have immune paralysis measured by ex vivo TNF response and a ferritin level less than 2,000 will be randomized to placebo or GM-CSF. Patients who have an ex vivo TNF less than 200, which is immune paralysis, and a ferritin over 2,000 will be randomized to placebo or anakinra or tocilizumab. Because as Dr. Abbas showed, you can have immune paralysis from not enough immune function, but you can also have it from a hyperinflammatory state that is turning off your immune paralysis, your immune function. So that trial will take 5 years to see. But we know if you don't do it, Aga Khan is one of the world's finest hospitals, and you have the capability to do everything we do. But throughout the rest of Pakistan, I assume that many of the people who are on the call can't do the ex vivo TNF response. You can look at 2 consecutive absolute lymphocyte counts less than 1,000. The second question was hyperferritinemia versus macrophage activation. Is that right?
Yes.
Yeah, HLH versus
Yeah. So
MAS.
hyperferritinemia is just a high ferritin. Macrophage activation syndrome is when you have the combination of hepatobiliary dysfunction and disseminated intravascular coagulation. The way we treat those syndromes is, as Dr. Abbas said, if we see that, we give IVIG and pulse methylprednisone. And if we have TAMOF with it, thrombocytopenia with it, we do plasma exchange. And if you don't have TAMOF with it, you will also add anakinra to the IVIG and the methylprednisone.
All right. Thank you very much, Pastor, for adding it into it.
Yeah. So can I add
Yes,
into
Arun.
this? Please. Yeah. So I think these are the great comments by Joe. And we would be very excited to see the results of this study on GM-CSF versus placebo, though it's going to take some time, but still it's worth the wait. Whatever experience we have of GCSF is mainly, like Dr. Joe said, is in oncology patients and few times in oncology with febrile neutropenia, or in sometimes in severe sepsis also. We've seen that it does show some improvement in the total count and the neutrophilic count, but it has not shown any benefit with survival. So we haven't seen any difference in either the ICU stay or this mortality benefits in that. Maybe Dr. Carcillo, you have any comments on that?
Yes, I just want to clarify that we're talking about granulocyte macrophage colony stimulating factor, not granulocyte colony stimulating factor.
Yeah.
So just so everybody knows, so the granulocyte colony stimulating factor does not restore your immune function. It simply restores your neutrophil count. In the trials that have been done so far for GM-CSF, we've seen it reverse acute respiratory distress syndrome, and we've seen it reverse or prevent nosocomial infection. The reason we're doing this larger trial is to see whether there is a mortality effect. So at the end of this study, we'll be able to see that. We're pretty confident that it reduces neutrophils in the lung while improving your ability to fight infection. We'll find out from our study if it has a mortality effect, but it's not GCSF, it's GM-CSF.
Yeah, thank you so much.
Mm-hmm.
Yes, I think that provides a very good direction, as to how one could actually potentially use GM-CSF. And again, I agree with Dr. Arun that I think the only areas of patients, if we've used this, is probably the GCSF and all, and Filgen, we've used it in oncology patients only. So again, it will be very exciting to see the results. Okay,
Akash has a raised hand, I think.
Yes, I was coming.
Akash. Yeah.
Hi. Again, Abbas, it was a great talk. Thank you. You've taken us through a journey of immunology to immunopathophysiciology to management. So it was fantastic, as Joe said. My question, either it's for you or for Joe, is, we have all heard and talked about PIMS-TS and MISC, and people are talking about it. So how easy, or because we have entered into an area, at least in the UK, where people are very scared to call sepsis. It's being labeled as PIMS-TS. People are worried about, we never used to measure those parameters before. Now, all those parameters are being measured, like the D-dimers and the things in sepsis. Now, they're coming high. People are saying it's PIMS-TS. So my question is, how easy or difficult it is to segregate these two, PIMS-TS, MISC versus sepsis?
I would just give a very brief answer because I have a brief understanding. What I think, generally sitting in a resource limited setup, we have generally dealt sepsis as a sepsis, COVID patients as COVID cases. So basically, we actually did not. I don't think we actually have gotten to any sort of trials to actually see the overlap between general sepsis and the COVID sepsis and the COVID patients. So we generally have gone through the same pathway. So I don't think that I have any better understanding of the differentiation. I'll just skip this question for Dr. Joe and for my learning as well.
So Akash, the MISC PMIS, where it's an immunologic response, should only be considered if you are not PCR positive. Much like if you were to look at the measles or serum sickness from other infections, you don't call it serum sickness or SSPE unless it's long after the infection. I think the confusion is when people use the term MISC or PMIS in patients who have acute COVID infection. And the definition of PMIS and MISC and the definition of sepsis are the same. It's inflammatory markers plus organ failure. So as an intensivist, you would call a PCR positive SARS-CoV-2 viral sepsis. Now, the reason that the SARS-CoV-2 looks like sepsis is because the spike protein is a superantigen. And so staph is a superantigen, strep is a superantigen, mycoplasma is a superantigen, which means that rather than activating like 0.0007 T cells, they activate 3% of your T cells, and so you get the hyperinflammatory condition. The real question is, should you be putting MISC, PMIS patients on antibiotics? And when you look at the initial definitions and how to treat, they say you should. So if you're putting someone on antibiotics who has multiple organ failures and inflammation, I would say you're treating sepsis. If you have a patient where you believe that they are having an immunologic response a month later from a distant infection, and you're not putting them on antibiotics, that's when I call it MISC, PMIS, and it's a spectrum that can look like toxic shock, it can look like Kawasaki's, it can look like myocarditis. And it's treated with anti-inflammatories, not with antivirals or antibacterials. But that's just one man's opinion, Akash.
Now, point well taken, Joe. I think we completely agree. But what it has done to the world of intensive care is that every patient, for example, last night I was called in to see a patient to say, oh, the patient is tachycardic, had a COVID contact 3 weeks back, and we want to give methylpred or we want to give IVIG. And the question is, why is it not sepsis? And why are we treating it differently? And why do we want to give methylpred and IVIG? Yes, the D dimers are a bit raised. Yes, the ferritin is a bit raised. So the thing is, it's kind of changed the way we are starting to treat sepsis, and every sepsis patient is being labeled as PIMS-TS. And that's the problem.
Yeah, I think that is a big issue. A big issue. So hopefully when the virus is under control, which it should be as the vaccines go around the world, we'll be able to have a little more clarity with it. Many of the patients who are MIS, who in our institution, many patients who people are entertaining MISC or PMIS actually have Epstein-Barr virus, they have streptococcus, they have staph. Yeah. And the reason we can see it is we have a very, very low incidence of SARS-CoV. And we have been treating what I call red sepsis or hyperinflammatory sepsis for many years with methylprednisone and IVIG, as Dr. Abbas showed, as being one of the treatments for the hyperinflammatory macrophage condition, activation condition. The real question is, do you also give antibiotics or not?
Mm-hmm. Yeah, absolutely.
Dr. Carcello, I had a question. Like, since you probably, the lead on ferritin, so, is there like any specific level of hyperferritinemia that's been associated with, worse outcome? As to what level does one end up treating? You may see levels in thousands, you may just see levels that are less than 5,000. So, for us, if we're talking about a resource-limited setting, so does every high ferritin, warrant a treatment?
Wonderful question, Dr. Shak. It is location specific. So if you are in Southeast Asia where dengue is very endemic, and during the dengue epidemic, everybody has hyperferritinemia. Your ferritin levels have to be above 1,000 because you have hemolysis and viral infection stimulating ferritin production. You have to be above 1,000 for it to predict severity. In our ICU, you have to be 1,000 for it to predict severity because we're just so technologically blessed. In Brazil, they found that 500 was the predictor, but in their most recent papers, it's over 300. And when we looked at our own hospital, a ferritin over 378 was associated with 7% mortality in our hospital. A CRP over 7 was associated with a 7% mortality in our hospital, and the combination with a 21% mortality. And if your CRP was less than 7 and your ferritin less than 378, there was no mortality in our hospital. So it really has to do, even within a hospital, your setting. So you have to, at Aga Khan and at all the various centers that are on this webinar, you have to screen your patients for a year or so to see what ferritin levels are actually associated with poor outcomes, and then identify the group of patients that you would like to try IVIG and methylprednisone. And as Akash says, in the UK, it's heightened now because of MISC, but really, they're just treating the hyperinflammatory sepsis. And hyperinflammatory sepsis, as Dr. Boss so eloquently showed, is the pathophysiology of, is treatable with IVIG and steroids.
Yes, I think point very well taken. Thank you for that, because, a lot of times what we end up doing is actually, coupling both the steroids and the IVIG together, because, we're not really kind of, taking the level of ferritin into consideration. It's just the high ferritin that needs to be treated. And so, you would start off with steroids, and then, of course, some hours down the line, you do an IVIG. So I think this is something that definitely needs to be looked into, like you've mentioned. Thank you for that. I'll move on to the next question. So this is by Dr. Ataullah Khan. He happens to be a pediatric intensivist in Islamabad, and he has a question regarding ADAMTS13. And he says that, does ADAMTS13 result being positive or negative change our management of atypical HUS? So Awais, I would like you to take this question first, and then we can move to our panelists.
Okay, so up to my understanding, since we know that in that particular phenotype of sepsis in which we encounter a low level of ADAMTS13, that is obviously associated with increased incidence of microangiopathy. So can I exactly get the question? So what you wanted to ask?
So he's actually asked a question regarding atypical HUS, and he's asked that whether ADAMTS being positive or negative or equivocal make a difference to the management of atypical HUS. How important do you think? Because for HUS itself, you mentioned that ADAMTS13 is important, right? For the atypical ones, the criteria are different. So would the positivity or of ADAMTS13 actually, affect the way you would manage your patient?
So I think the important factor that would affect, up to my knowledge, that would affect the management of the patient, be it a typical HUS patient or an atypical HUS patient, would be the presence or absence of the microangiopathy and organ microvascular occlusion. So if that happens to be the fact that the patient has got microangiopathic manifestations, be it a case of typical or atypical, I think that is the factor that will determine the morbidity and mortality. So yes, so I mean the microvascular the pathology is the thing that I think that should matter the most, not the typical or atypical aspect of a particular disease.
So what we do, Dr. Shak, is if your ADAMTS13 is low, then we start with plasma exchange, because the mediator, as Dr. Abbas is saying, is in that beautiful slide he showed, is in fact amenable to plasma exchange. And we don't think about adding eculizumab because it's very expensive. And eculizumab also, in the face of a bacterial infection, it can make you very susceptible to bacterial infections that depend on complement for killing. But if we would only add eculizumab maybe a week or so later, once the patient was outside of their infection, but was still bound to the dialysis. to get them off of dialysis. Whereas if we see someone who doesn't have a reduced Adams 13, then we think more about, is this actually a complement-driven disease process? And we think more about the eculizumab. Whether or not we would start it or not has to do with how the patient is doing. We might still plasma exchange, but we'd be more likely to lean on higher amounts of steroids, things to reduce complement. So mostly, to answer the question, we use it to try and prioritize, do we really want to use something like eculizumab or not? When you look at complement activation, looking at C598, it's not that accurate, but we would use that as well. But eculizumab is extremely expensive, even for the US, and has long-term implications, short-term in the acute sepsis, and then long-term. So that's how we use it.
Dr. Arun, would you like to share your thoughts on this question?
Yeah, I think the same thought that ADAM 13 positive means deficiency or normal will differentiate between the TTP and the HUS, though means atypical HUS, you can have some complement factors which might play a role other than the compared to the typical HUS, that's the diarrhea induced or the Shiga positive. The treatment obviously means if it's deficient, we like in, I think same it's in your country also, we don't use eculizumab. It's not available even. The cost is a next factor. So we use the plasmapheresis in these cases. So that's what we do.
Right. Thank you. I hope that clarifies the question. So I'll take one more question before I hand the floor to Dr. Naveed. So the next one, Wes and dear panelists, is on steroids. So this is by Dr. Gulsher. So he's our pediatric critical care fellow who's currently training at the Phoenix Children's Hospital. And so his question is, so there's a general fear regarding the use of steroids, especially in viral illnesses, and that may lead to further aggravation of the disease process. So how true is that? And should that actually preclude the use of steroids, especially if you're thinking in a day and age of COVID-19?
So I'll try to answer it first. Since the COVID pandemic has arrived, so what the clinical things that we have seen is that there has been a surge of hyperinflammatory markers in patients. So basically, the thought process, as far as I know and I've studied, the thought process of starting steroid is actually to treat that surge of hyperinflammatory state that has been classically associated with COVID. So that thing is that warrants us to use steroids, but definitely we do not. It is a correct point that he made that we are a bit reluctant while we consider steroids in any of the viral illnesses such as HSV. So I think the factor that possibly encourages us to use steroid is the hyperinflammatory state that has been generally seen with the COVID infection.
Dr. Carstio, your two cents.
Right, the way we approach it is we do it based on ferritin levels. So a study by Wang and colleagues shows that the hyperferritinemic response occurs when you've had a sequential exposure, first to viral antigen, then bacterial antigen. But not viral, then viral, not bacterial, then viral, not bacterial, and bacterial. So the reason you use steroids in a viral infection is if you have a high ferritin, because that means this patient is now in macrophage activation, and you have to turn off that macrophage activation. And the only way you can turn that off is with steroids and IVIG. And if you look at the COVID patients, they don't just have a high CRP and ferritin, they also have a high procalcitonin, which means that they had a viral infection and now they've been exposed to a bacterial antigen. Now, whether it's a true bacteria, in which case you would use antibiotics, or many of them have abdominal pain and it's just endotoxemia that is stimulate the procalcitonin, it doesn't matter. Now, we still don't use steroids when we have disseminated herpes simplex virus. That does seem to be a virus that really doesn't like use of steroids. There we'll use anakinra and IVIG. So if you don't have anakinra, then you would use IVIG with HSV. But it's all about the ferritin. If the ferritin's high, we use steroids.
Thank you very much. I think the points were taken. If the panelists agrees, because it's almost 9:30, and if they have time, can we take more questions, or we can conclude?
I'm okay.
I'm fine.
I have one question. I would like to take advantage of Dr. Zhu's presence.
Yeah, please go ahead.
Okay, so taking the point from that infective etiology, so Dr. Zhu, can you actually, are we able to link any particular, I have two questions, I'll be very quick with those. Can we actually link any particular pathogens to a particular phenotypes, number one? And number two, what are the factors that you think are responsible or predictive of these phenotypes jumping into the MAS category?
Great questions. Okay, so the classic, we have if you go to pediatric clinics of North America, you'll see we have a paper there by Pod and myself, PODD, where we talk about all the specific pathogens, and there are in fact pathogens for each of these. So influenza, H1N1, causes immune paralysis, and then patients die of MRSA with immune paralysis. Gram-negative infections, including meningococcemia, but also, as you mentioned, Shigella, they cause direct endothelial damage and they cause TAMOF. And they die unless you give them antibiotics and plasma exchange. And as you know, atypical HUS is also triggered by gram-negatives, but other infections as well. Sequential multiple organ failure, for the most part, is triggered, as you showed, by Epstein-Barr virus. Is one of the big ones. And then macrophage activation syndrome is seen with the hemorrhagic viruses like Ebola, dengue, Crimean hemorrhagic fever, and now COVID. And basically, it's that they have the viral priming, and then they get the secondary bacterial or antigen effect, plus they have some degree of endothelial injury and D-dimer. So those are the specific pathogens. So what kicks you into macrophage activation syndrome is, as you pointed out in your elegant talk, have you been able to get rid of your infection? So if you've been able to get rid of your infection and don't have immune paralysis, you're fine. But if you cannot get rid of your infection, as that infection continues to proliferate, even if it's dead, you just can't get rid of the as you said, the DAMPs and the PAMs. That's what kicks you into macrophage activation syndrome. And basically, macrophage activation is when your inflammation is so high that the macrophages are basically eating your body. So you're eating yourself. You're basically eating yourself. It's auto. I don't know the exact word, but we saw an autopsy this past week of a child who had ALL, and they treated the ALL. They got rid of the cancer, but when we looked at the autopsy, there were macrophages everywhere eating the child from the hyperinflammation. So it's all about inflammation, turning off the inflammation and deciding if the inflammation is coming because you can't get rid of the infection, or it's coming because you have a disordered immune system. And not to make it too complicated, but the reason it occurs is that we have something in our body called nonsense-mediated decay. So when your cells see nonsense RNA, like an RNA virus, for example, it has a mechanism to get rid of that. Okay. We make nonsense RNA every time, but of the 6 of us that are on the call now, we each make a different nonsense RNA. When you become critically ill, or you have viral infections that inhibit your nonsense-mediated decay, you're going to express genes that you normally housekeep and get rid of. And so you're going to have autoinflammation or hyperinflammation or immune paralysis or any number of disease processes based on your individual genetic makeup. And then whether or not the virus or hypoxia or, as you said, endoplasmic reticular stress, whether or not that overcomes and stops your housekeeping mechanism. So that's a little deep, but that's why. So it's sequential, viral, then bacterial antigen. That's what stimulates you. And then it's, once that happens, it's your own DNA and your own message that determines your response. And there are certain responses that are more common, and that's what you have different phenotypes that you present with.
All right. Thank you very much, Dr. Arcelo, for getting into it and points well taken. We'll move on to the next question. This is from Dr. Parav. He is our colleague fellow in Khan University Hospital, Peds intensivist. He has asked few questions, I think so specifically from Joe Arcelo. Can phenotypes change with disease evolution, like one changes into another? And also, are there any ways to predict these phenotypes earlier, such that if we can use certain physiologic signals to predict these phenotypes?
Great question. So you will see these phenotypes can in fact evolve over time. And in addition, if you don't get rid of the phenotype, you'll see MAS occur. So MAS will be the final end pathway. And we have a paper right now that I'm going to upload next week in Medrix, which is the preprint phase without peer review. But what we've done is we've taken 25 bedside variables, including CRP and ferritin, and using machine learning, you can identify subtypes. And we do identify a group for you that at 24 hours, you know is at high risk of developing MAS and all the other phenotypes, including immune paralysis. So the answer is yes. This paper, if you want to go to Medrix in a couple of weeks, it'll be uploaded. It takes a long time to get things published, but yes, you'll have something where you can go to the computer. We have a website, you can go to computer, you can put the 25 variables in and then predict the risk of your patient developing these phenotypes. And then say to yourself, okay, I'm going to watch for these phenotypes and start having a discussion before it happens. So your awareness is heightened.
I think so. That would be great. Now we will be eagerly looking for it, for sure. So, do we have other questions?
Yes, I had a question, and if everybody could share their experience. There's this, thing that is pulse steroids, right? So we actually using the pulse dose in a lot of patients where we actually think this is MORS versus MAS and all of that. So is there like enough evidence to suggest pulsing versus like routine steroids versus the 2 gram per kilo dose? Has there been, I don't know, we haven't been really able to, come up with a lot of evidence from whatever we source. So I think, you guys could go ahead and share. And maybe Dr. Kash could also, share his experience.
Do you want me to answer that?
Yeah, please go ahead.
Yeah, so the thing to understand about pulse steroids is that when I started in intensive care, which was 1987, we routinely gave everybody 30 milligrams per kilogram of methylprednisone every 8 hours for the first 24 hours. there are 3 trials, randomized trials in sepsis. The first one showed benefit. The second one showed no benefit. Third one showed an increase in secondary gram-negative infections, nosocomial infections. So it was dropped, but that is the sum total data on pulse steroids in sepsis. All the other data in pulse steroids for MAS comes from the rheumatologic literature. Now, intensivists do randomized trials. Rheumatologists do not. They do phase 1 and phase 2 trials, but not randomized. So you can go through their literature and you'll see, but basically they just show that they gave pulse steroids and biomarkers went down. There is no randomized trial of pulse versus not pulse. There is one very interesting, Marrow showed that if you give 50 milligrams per kilogram of hydrocortisone, which is closer, but it's still not like a pulse of Medrol, that he had benefit in survival with dengue shock. And then when they went to the lower dose, they didn't have a benefit, but that was not comparing the two. Those are just 2 separate studies. But that's the literature as far as I know.
Yes, because I think we've yet to define as to, who do we need to go ahead with steroids and whether pulse dose versus you started with IVIG. Now that we've actually started to get some understanding and, some recognition of these phenotypes. So again, but I think it's a long, long way to go. Dr. Arun and Dr. Akash, if you could share some thoughts on that. Yeah.
Yes, sure. So we have a patient now, Sidra and Joe, we have a patient who's undergone CAR T therapy for BLL, and that patient is in multi-organ failure requiring all sorts of support. And here is a patient who we have started 10 milligrams per kilo of methylpred for 3 days. And then the second indication, of course, is a cytokine storm of so-called PIMS TS when they have got coronary abnormality, and that's the indication, at least in the UK, of giving 10 milligram per kilo. But otherwise, we do not use pulse methylpred very frequently in our setup.
Yes.
Like again said by Dr. Joe, we don't have an evidence on that, but yes, we use pulse therapy in hyperferritinemia and also now in MISC. So, and that means like it's whatever our experience, no randomized trial, but it does show some benefit in getting these markers come down to normal early. That's what we assume early, means we don't have a comparison to it, but it does make a benefit, yes.
Right. So the next question is by Dr. Ataullah, and he's asking, is there any role of rituximab versus vincristine besides plasma exchange or eculizumab? Because eculizumab, again, as we discussed, is like very expensive therapy and not available. So Ritux again is expensive, but we've used it in very, very rare cases. So he's asking if vincristine may be a choice or an alternative.
So so when you're by vincristine, do you mean etoposide or you just mean or a different drug?
No, vincristine is going to be different. It's not etoposide.
Okay. So the way that we are you talking about for which phenotype is the doctor talking about?
Maybe it's for HLH?
Yes, I think it's HLH because that is what it seems like. Because if you mentioned eculizumab, yeah.
Yeah, so for EBV related HLH, you use rituximab. For HLH that's not related to EBV or including it, we generally will use etoposide, but vincristine would be fine if you don't have etoposide. Okay. Now, to me, I think one of the questions was, how do you define HLH versus MAS?
Yep.
HLH is a chronic condition. These are children who have been sick for months. They've had a big liver and a big spleen for months. They're generally failing to thrive. And HLH doesn't go away after the sepsis episode. Macrophage activation syndrome is an acute process. The child was well, and now suddenly gets very sick. So that's the best way to think about it. The HLH kids might come to you because they're failing to thrive because they have such a big liver and they can't eat. And you can just slowly see them moving down that range. If you can do NK cell counts, if you just do the, I don't know which hospital you're at. I know at Aga Khan you can, but if you do the NK cell count, natural killer cell count, the natural killer cell count with macrophage activation syndrome is less than 10% of normal. The natural killer cell count with HLH is normal. The cytotoxic T lymphocyte count, or CD8 cell, with MAS is low, less than 10%. With HLH, it's normal or high.
Right. So, Dr. Carcello, that just brings me to one other question. Like, I agree to, kids with HLH being, chronically sick and, of course, presenting in, a much more moribund state than the rest. But again, having said that, there's something that we end up labeling as secondary HLH, that probably is like more of an acute phenomena. There's something that is sepsis induced, and this is probably, secondary to that. And they may actually be pretty much, there may be an overlap between secondary HLH and MAS. So how does one go about distinguishing that category?
Right. So I think the question is similar to what Akash was saying with MISC and PMIS. The reason to distinguish MAS from HLH is in HLH, you have a lymphocytosis, and you need a lympholytic therapy. In macrophage activation syndrome, you do not have a lymphocytosis, and you do not need a lympholytic therapy. So that's why I look at the lymphocyte counts, specifically the NK cell and the CTL cell, to tell me what's happening. If I have normal CTL cells and normal NK cells, then I might need a lympholytic therapy. Now, if you don't have the ability to do those, it turns out that IVIG, high-dose steroids, do you have anakinra in your country or no?
No, we don't have it.
Okay, so it turns out that high-dose steroids and IVIG will reverse macrophage activation syndrome and HLH. But HLH will continue, just will not go away. So if you do plasma exchange, IVIG, and steroids, do you have plasma exchange, I assume? Yes?
Mm-hmm.
Yeah, we do have.
Yes,
So if you do IVIG, steroids, and plasma exchange, MAS will go away, HLH will not. So if 3 to 4 or 5 days later, after you've done pulse steroids, IVIG, and plasma exchange, this patient just isn't getting better, then I would add the lympholytics. Decide if it's B cell, decide if it's T cell. That's how I would approach it. But if you can get your, so you start with IVIG, pulse steroids, plasma exchange, send off your cell counts. How long does it take for your cell counts to come back? Your T cell subsets and B cell subsets.
Usually it's almost 10 to 12 hours.
Yeah, so the next day you'll have a good understanding of what you're looking at, right?
Yeah, I think so. That would be really helpful, and we would be able to differentiate it.
And if you look at the study by the Merkel, which is to your west from Turkey, so different, obviously different people, but in terms of the socioeconomic level of country and of your hospitals, exactly the same, I think. Although Aga Khan, there's no Aga Khan in Turkey, but you know, you guys are very high level. But if you take the average hospitals of Pakistan and you take the average hospitals of Turkey, they're very similar. And in this study by Demirkol, if you want to look it up, Demirkol, steroids, IVIG, and plasma exchange saved all the kids with MAS or HLH. So regardless of what you're looking at, within 5 days, if you do 5 days of plasma exchange, pulse steroids, and IVIG, your kids will get better. The ones who aren't getting better, they are the true HLH who actually, either they're cancer, right, where it's a kid who has a cancer, has cancer cells that need lympholytics, or it's HLH, which are non-cancer lymphoproliferation. And then you need lympholytics.
So I will move on to the one, I think so we would take the last question. If there is any, what is the role of IVIG in pediatric asthma, MAS, and TMOF?
Yeah, so a paper is coming out. I'll only say it if you don't spread it out, but a paper is coming out from the MISC PMIS group in the United States showing that the combination of IVIG and steroids reduced myocardial injury, improved myocardial function in the MISC PMIS patients. So IVIG and steroids together are much better anti-inflammatories than either is alone. In the paper that I'm going to upload, you'll also see that when you look at it next week, hopefully I have it uploaded by next week in Metrics, you'll see that in the machine learning phenotype that predicts all our phenotypes, the combination of IVIG and Solumedrol reduces mortality twofold, whereas IVIG alone or methylprednisone alone does not. So the combination of methylprednisone and IVIG, again, no randomized trials, but using what we have thus far, the methods we're using thus far, they have a synergistic effect on reducing inflammation and preventing organ injury.
I think so.
Yes, I
Yes,
think just one comment. On this, there's already one paper got published in JAMA Pediatrics last month on this IVIG plus steroid versus IVIG alone in MISC, which there were, I think, 50 odd patients in both the arms. So they've shown that IVIG plus steroid had no mortality versus IVIG alone group had almost, I think, 20 or 22 patients died out of 60, 70 patients in that arm. So yes, both these a combination of these two drugs do have a significant beneficial effect.
Well, Dr. Bansal, who's the first author there, so I can put that in our references for this paper I'm going to upload?
Just give me a second, I'll get back. Yeah.
Okay.
Just give me a minute.
Thank you.
Dr. Naveed, are there any further questions on YouTube, or I'll just take the last 1 or 2 questions and before we can call it a wrap?
I think so. You can proceed.
Okay. All right. So okay. So another question by Dr. Kalib Abbas is there any role of nutritional status, malnutrition specifically, to the development of a particular phenotype?
Yeah, I think that is work that you can do in Pakistan. But my answer to that would be most likely, right? Because in the US, we don't have much malnutrition. So most likely, yes, because the immune paralysis more than likely is much more common if you're malnourished. Mm-hmm. Mitochondrial dysfunction and therefore macrophage activation syndrome should also be more common if you're malnourished, because we know that specific defects in metabolism related to vitamins, abnormal vitamin pathways or coenzyme pathways or protein pathways, et cetera, do put you at risk of getting macrophage activation. So the answer is most definitely, but I don't know personally of anyone who's studied it, but if you have a lot of SAM, what they call SAM, it would be a really good thing to look at.
Right. And Dr. Carcello, I just had a, one final question. That in your experience, have you seen like, a combination of phenotypes happening? Like we've already seen that we've teased out each one of them separately, but, have you seen more than one phenotypes existing in, a patient who presents with, let's say, MODS?
Absolutely. So the phenotypes that we see, as Dr. Abbas showed you in those circles, overlap. We very rarely see so in that study and in our multi-center study, 80% of the time it's a single phenotype, but maybe 1/4 of the time it's an overlap of phenotypes. So the way I practice is if you have, oh, thank you. I'll write this down here. Udali, thank you. So the way I practice is if I have prolonged lymphopenia, I use low-dose GM-CSF if I don't have a high ferritin. But if I have a high ferritin, I'll use Cymedrol and anakinra. If I have macrophage activation, I'll use Cymedrol, anakinra, and IVIG. If I have TAMOF, I'll use plasma exchange. All of the SMOF patients become MAS or macrophage activation syndrome in our paper, so they get treated the same way. So our sickest patients that we have are on IVIG, steroids, plasma exchange, and anakinra, because our sickest patients are macrophage activation syndrome patients. The SMOF patients, which are very rare, they're like 1 in 50, those patients will treat with IVIG and rituximab, or IVIG, anakinra, and zydophivir, depending on what the virus is that we're treating. So yes, we commonly see overlap of the phenotypes. So the way where you are now today is you're well versed in the fact that if a patient comes with septic shock, they might be hypovolemic, they might have a low cardiac output, they might have a low vascular resistance, they might have a high lactate. If they're hypovolemic, you give them fluid. If they have a low cardiac output, you give them an inotrope. If they have vasodilatation, you give them a vasopressor. And if they have high lactate, you give them thiamine. So many of your patients you'll be doing all 4 things to because they have all 4 phenotypes. Some patients you'll be doing 2 of those things because they have 2 of the phenotypes. So what we're doing in this work is we're saying that when you do wonderful care up front, early recognition and treatment, you save 90% of the patients. But we still have 10% that are left that are dying. And we know that you can identify them from the C-reactive protein and the ferritin on the first day. So if their ferritin and CRP are not elevated, they're going to live. But if they have a high CRP and ferritin, they're in the group that go on to die. Now, if you make their CRP and ferritin normal, they're going to live. But if you continue to have high CRPs and ferritins, it's either because you haven't gotten rid of the infection and or you now are manifesting these different phenotypes that have to do with the combination of the host and the pathogen interaction. And if you can target those therapies, just like you target hypovolemia, low cardiac output, vasoplegia, or thiamine deficiency, if you can target those while trying to figure out how to get rid of whatever infection it is that you're not getting rid of, your patients will do better.
Thank you so much for enlightening us tonight, with all that mega information. I'm sure, like, each one has a lot more questions, but I think we can call it a wrap, Dr. Naveed, if we
Yeah, I think so. It's almost 10 o'clock now. We got almost 30 minutes passed by, so we can.
Yeah, and if any of you want to do any investigations, I'm happy to help you.
Yeah, I think so. That would be great.
Absolutely.
And my time is your time. I am. You can ask Akash. We collaborate on many studies without traveling to see each other. We do it over the internet. So it'll be my pleasure, right, Akash?
Absolutely, yeah.
I think so. That would be great. And thank you very much to Joe Garcillo and all of the panelists for enlightening us with that much great discussion, especially in our resource limited setting, how we can go about these phenotypes. That was really fantastic. And,
yeah, you only steroids, IVIG, and plasma exchange, and you have all three of them.
Yeah.
And it's just a matter of figuring out which groups of patients benefit at what time, with what dose.
Yeah, that's the $1 million question.
But that's where you can lead. But that's where you can be a leader, right? Because you have the resources to do the studies to answer those questions, and they don't have to be randomized controlled trials. That's why I'm saying I can teach you many different techniques other than randomization. Because we all have different cultures, and some cultures don't like randomization. So there's other ways we can do it.
I think so. That would be great, and we would be looking forward to it.
Thank you. Thanks, Dr. Abbas. It was a great presentation, and thanks, Sidra, for having me here. Thank you.
Yes, wonderful talk, Dr. Abbas.
Thank you so much. My pleasure.
Yeah, and thanks for the honor of spending the morning with you.
Thank you, Dr. Sidra and Naveed, and it was an honor to share the experience and hear from Joe. It's really great. Thank you, especially Joe, for your comments and insights.
My pleasure.
So thank you so much, and
the
thank
honor
you,
is mine.
Abbas.
No, absolutely. Dr. Carcello is such a powerhouse, So, we were kind of a little intimidated also when we were preparing a ways for the presentation, because of course, we yet in infancy and, at very preliminary stages of just trying to figure out. But I think it's been an absolute honor tonight to have Dr. Arun, Akash, Dr. Carcello with us, and you all were so patient with our questions, and I'm sure we have so many things to ask you. But again, as long as you've given us a direction and a thought process, so I think that should help things going. And we'd be looking forward to collaborative projects, research, and willing
I'm happy to do this again also anytime you like.
Yeah.
Thank you.
Sidra,
and thank you, Sidra, for getting us in touch with Akash again today. So it was nice to meet you.
Yes,
Sidra, can I just tell you a secret about Joe? So if you want to get an email reply from Joe, you need to write in the subject sepsis query, and he will jump up from his sleep at 2 o'clock in the morning and he will answer your email. Okay.
So we'll keep that in mind whenever we don't hear back from him, like in the next 10 or 12 hours.
Thank you, guys. Lovely meeting you all. Bye-bye.
Thank you very much. Thank you very much, everyone.
Wow.
And we're going to meet.
Bye. Good day.
Thank you so much. Good evening and take care. Thank you.
Bye. Bye.